the Congress took. But before it was like you have to pay for that one, but now it is free according to under that CARE Act law in the US. And the main concept is how we can prevent the spread at this point. And it has individual contribution as a community contribution that takes part in that one. The other thing which is really important is that provide resources to the healthcare system, because no one was ready across the globe to face those challenges. So we should make sure that in our community level, at small clinic to the bigger hospital system, in the rural area or urban area, we have those resources. We should not get panicked. Oh, this get COVID, so we should be afraid of. No, as a community, we should come together, help each other, make a best practices that what we can do to contribute ourselves. Make sure we are washing hands, keeping distance, keeping people, if they are having some symptoms, we should go and get them checked out. Then we have a healthcare system, we think as a community, but think of those people who are at the front edge treating you guys in the hospital system. So that's where this thing affects a lot. Like we have nurses, we have paramedics, we have a lot of staff. So training of those frontline workers is the key to help those people to make sure that once they enter in the healthcare system, there is no more spread. I can give you my example. I'm a graduate for Nishtar Medical College. So I came to know when this thing happened in April that a lot of people, doctors get infected with the COVID. So I have to arrange the COVID-19 from here through my alumni association and send those kits overnight. About 400 tests we send over to just a free test as a donation. So we got some donations, we paid there. So I arranged kits for them there. And then unfortunately, our VC Vice Chancellor, Dr. Pasha, died due to the COVID. So it is very unfortunate in those systems that as a clinicians, we are working in that health system and we are not taking care of ourselves. Our systems are not ready. So making sure that we have a system in place, we share our practices. If your department is doing really great in that one, we learn from your best practices, train our workers how to fight or combat these COVID-19. So at the last, I would like to say, I think I have few minutes, just almost over. So social and economics determinants of health. The social and determinants are the key to drive those performances, right? I told you that if one person is affected, how much mental stress is there for that family? There are a lot of people, you have to be quarantined. You need a space for that. Like all of you are working from home. Were you ready to work from home? Do you have a system in place? You have internet band, you good connection, you have laptops available. So all those things take part and better prepare, but it also drives who's going to pay and who can afford it. Do we have the resources? But we can do it as a community level, come together, do what we can do to make those practices and share those ones, and try to understand as a nation how we combat not the COVID-19, but also the challenges which is coming. And mental health is the bigger issue, what we face here in the US and also on across the globe. So we have to be ready to give a listening hand to those, listening ear to those people who are suffering those challenges, and try to communicate in a best effective manner on the best practices and take our part in the community level, arrange some awareness events in the community and tell them that these things you should be doing, and make sure that they understand very clear, because the communication sometimes is a barrier. So I'll stop here because I think my time is over, and open up any questions, or I don't know, it means you guys have questions at the end.
Thank you, Dr. Zishan, for sharing your knowledge about the pandemics or the post-pandemics of the COVID-19 on the health and community. Dear audience, is there any question regarding early screening and treatment of the cervical cancer? Currently, her research is focused on understanding the roles of extracellular vesicles in immune evasion during the HPV-induced cervical carcinoma. With the onset of the SARS-CoV-2 pandemic, she is interested in understanding the immune factors contributing to protection against the virus and in immune correlates of the progression to the severe disease.
Okay, well, thank you very much for this invitation to speak, and thank you very much to Dr. Shahjahan and Javed, Vice Chancellor Javed Akram, for the honour of being able to speak here. I will give an overview of the New Zealand perspective of SARS-CoV-2, because I know you may be interested in our situation being somewhat different to a lot of other parts of the world. Now, I have to acknowledge Dr. Mazhar Hassan, who's prepared these slides for me, and his light-hearted humour has been added as a touch, and I think this is a good time to demonstrate some of that, to just take a break from the seriousness of this particular situation. So for those of you who don't know where we are, we're just a very small island, or a couple of islands way off in the southwest Pacific. We consist of two main islands, but most of the population is actually in the top half of the North Island. So we have pretty dense population around the city of Auckland, but our capital is Wellington, and we are actually situated down here in the South Island. Estimated population is about 5 million, but probably almost an additional travellers. And so we do like to be overseas. And this has been a feature of our SARS-CoV-2 experience, in that a lot of New Zealanders were caught overseas and have had a desire to come back. New Zealand never closed its borders to residents. So we have had an ongoing series of plane loads of people coming back who are potentially infected, around diversity. And we have Indigenous people, the New Zealand Māori. They're around 15% of the population, but we also have quite big Pacific communities. We still have some level of governance over a few islands in the Pacific, and historically have had very close relationships with many of the Pacific islands. And we see some level of responsibility around their health care as well. I have to try and change my slide, which is not working. Here we go. Okay, so we had our first case of COVID in February 2020, and 26th of February, and that person was identified and tested positive on the 28th of February, and that person arrived in from Iran, and we were the 48th country in the world to get COVID. But of course we were aware of what was happening. I think in a way there was a sense of perhaps disbelief that this was going to affect the world as seriously as it has, because there were things like the swine flu epidemic, which really didn't have a big impact in New Zealand at all. But SARS-CoV-2 has clearly had a much more significant impact. We started pretty early on comprehensive contact tracing, and our contact tracing system, I'm sure, is very similar to what many of you have in your countries, where there's a case that's identified. That person is immediately required to self-isolate. Any close contacts are also required to self-isolate. There is a series of tests that are carried out on those people, and all of that is reported back, and these clusters are reported on a daily basis on our ministry website. So we have done a lot of testing in New Zealand, almost 1 million cases, and considering we have 5 million people in the country, that's a commendable effort. We have a good testing capacity. It did take some time to ramp up, But once it did, we have seemed to manage on split shifts and intensive efforts from our laboratories. Our incidence of COVID, you can see at the peak of our activity, we had around 150 cases in a day. And of course, this is perhaps quite a different story to what many of you are experiencing in your countries. And we had around 22 deaths in total, with our peak deaths of 4 deaths a day in April. And this was effectively, if you could call it a first wave, this was the initial outbreak of COVID that then expanded and spread. And the key thing that New Zealand did when this was identified was respond incredibly quickly. So in a very short time, we were at level 4 lockdown, isolated in our houses and not permitted to travel any distance at all. So at the end of this first wave, we had cases in Waitemata and Auckland. Of course, our population density is up here, but we did have a significant early cluster in the southern region that was related to a wedding. Basically, our clusters are considered closed once we've had 2 of the 14-day incubation periods have been completed. So we went into lockdown very early on, as I mentioned, and New Zealand implemented this level system. So we have 4 levels, basically level 1's prepare, level 2 reduce, level 3 restrict, and level 4 is to eliminate. And this elimination strategy was put in place almost immediately. We had a couple of days of restriction, and then within a week we were all locked down in our houses. So this was a massive adjustment, and it's interesting to hear again the comments about mental health. In my view, I think there's going to be significant impact from that early lockdown, but also from the ongoing pressure that people are experiencing around this whole COVID situation. So one of the features of New Zealand was the introduction of the bubble, the concept of the bubble. And this was that you had a bubble that was isolated, you remained in your bubble, and you were not allowed to break out of your bubble. So even next, try again. Share. Okay, how about that? That's good. Sorry, apologies for that. Okay, so following our level 4 lockdown, the infections peaked, and basically everything then drastically decreased. So it was absolutely clear that if you maintain these very tight bubbles and have very, very limited activity, this is an effective way to drastically reduce the disease. And we reduced the disease to the point where we had effectively eliminated in a public health sense, but also eliminated the virus in an actual sense. So there effectively was no virus left in New Zealand. Okay. So the family bubbles, no mass gatherings, our shops were all closed, apart from supermarkets and pharmacies. And at that point, there was actually a reasonably clear directive from the Ministry of Health that face masks were not required. And this was coming out of the early work that suggested that face masks were not effective in the control of droplet-based infectious disease. Of course, we now know there is also aerosol spread, and we have now introduced face masks. So we dropped down to level 3, and the idea was that we would basically let things free up just a little bit. We opened a few more shops, and during this whole time, the borders actually remained open for residents to come in, but that was under strict quarantine. So we had 2-week quarantine in isolation hotels. So we dropped down to level 2 by the 11th of May until till June, and at that point things were much more relaxed. You could gather with 100 people. You have 1 metre social distancing in the workplace, and cafes and bars were open with table service. So in terms of the workplace, by level 3, research activity was allowed to commence, and but any work that could be done at home had to stay at home. But by level 2, all of that was freed up. So at the end of all of this, all the final clusters were closed out. Now, contact tracing remained active at level 1. We had basically intensive testing carried on, and the idea is if you stay at home and if you're sick, you basically don't come into work. And business was back to usual, which was, I think, a very positive thing. We still had the borders closed. But then, unfortunately, on the 12th of August, a case was identified through our routine testing, and actually as a result of some symptoms, in a worker in a cool store in Auckland. And this person, sadly, that person and his brother has actually now passed away as a consequence of COVID. But Auckland was very rapidly moved into level 3, while the rest of New Zealand was moved into level 2. So this was a difference to what we'd seen before. We'd had a national approach up till then. Our government was very much around the concept of a team of 5 million. And so it was very much act on behalf of the team. But now we had a situation where there was a cluster in Auckland, and Auckland was shifted to a different level to the rest of the country. The rest of the country went to level 2. And now we had this shift on face masks as well. So we had the introduction of face masks, which were mandatory on public transport. We brought in the social distancing again, and you can see there was again an increase in cases, but the daily incidence was nothing like what we saw in that first round of infections. So, at most about 14 or 15 people. But that has led to an overall case, number of cases in New Zealand of 1,815 cases and 25 deaths to date. So I think the New Zealand government has demonstrated that the idea of alert levels and having these 4 levels that we move up and down has been very successful. We've had very good compliance, especially early on. I think now as time progresses, people find this more difficult, and compliance becomes more of an issue. People get very wary of the whole thing and find it very difficult to make efforts when there's a relatively low number of cases. So that's a bit of a risk for this whole situation. In terms of the future, New Zealand has an interesting situation now. Because we've isolated ourselves very effectively, we are almost in a situation where it's going to be very difficult for us to ever freely open our borders unless there is a vaccine. And so this, of course, creates real challenges. A lot of our economy is based on tourism. It's a big part of our income. Tourism is now almost, as an industry, is almost defunct, apart from our local tourism. And 2-week quarantine is going to be mandatory and continue to be mandatory. There are other particular industries that are affected. Education is another, and I think that's a situation where perhaps it's a little bit more likely that we will allow people to come in for education, but it will be very tightly controlled. And we do charge for our quarantine now too. If you're not a resident, it costs you a bit over 3,000 New Zealand dollars to come in and stay in a quarantine hotel for 2 weeks. Now, there's also impacts on our Pacific neighbours. For example, I was on a Zoom meeting this morning with a group from Samoa, and they have an arrangement where people get surgery in New Zealand. And so this is really impacting on their healthcare, because those people are now not able to come to New Zealand and get the surgery that they need for their health. So I am a basic scientist, and there are things that are particularly of interest to me in terms of the basic immunology especially. And we have developed a collaboration with the group in Pakistan, for which we're very grateful, where we are still awaiting funding, but we hope to be able to look at the relationship between antibody responses and severe disease. Now, of course, in New Zealand, we can't really do much research on active COVID because there is no or very little disease to look at. So collaboration is really important. So it's very pleasing to be able to reach out to the people in Pakistan and build these relationships. Now, there was mention of the ethnicities, and I did mention the Māori, and there is different HLA representation based on ethnicity. And I think this is something we need to bear in mind in terms of vaccination, especially if vaccines become very specific or very restricted in how they're delivered and what particular viral proteins are delivered to the person. At the moment, there's a lot of emphasis on vaccines that will generate antibodies to the spike. But we do also know that antibodies may not persist in relation to natural infection. That doesn't mean to say a vaccine based on generating antibodies won't work, but we do need to keep our thinking broad about how these vaccinations might work. And in relation to people of various ethnicities, I think it's a case of just not thinking that everything is a one-size-fits-all and really looking at specific populations and making sure that we understand their responses to this virus as well. So I'll leave it there, and basically that's just given you a little bit of an oversight into our situation in New Zealand. We still basically sit on tenterhooks hoping that nothing else will come in, but we know that we're always at risk because we have ongoing cases in our quarantine facilities. And then really our challenge in the future is going to be, where do we place ourselves in a world where many people have been infected previously with COVID? So I thank you for your attention.
Thank you, Professor Hibma, for sharing your knowledge about the New Zealand situation in this pandemic. Audience, is there any question from Professor Hibma? I think no.
I can go ahead.
Thank you, Professor Hibma.
They want to ask questions.
Who?
I think it's Dr. Zishan.
Yeah,
Yes.
so thank you so much for a great presentation. Have you seen the B cell response for the COVID-19 in the COVID-19 positive testing?
So we haven't yet commenced our experimentation and looking at antibody responses. We're very interested in mapping epitopes. There are others in New Zealand who have looked at antibody responses in patients, and they are measurable. During active infection, people seroconvert usually around day 14. So yeah, they are detectable. Similarly, T-cell immunity, there's work out of the US that's looked at T-cells, and certainly active helper T-cells. There are fairly robust helper T-cell responses, but cytotoxic T-cells appear to be more limited in their repertoire.
Sure, thank you.
May I ask you a question in return, because I did want to ask a question to your talk, but I couldn't find the button to push in time.
Oh, no worries. You can go ahead if Dr.
If you
Shibata.
don't mind, sorry to commandeer, but I did have I was interested, again, coming back to the question of ethnicities and African Americans having a high risk of severe disease with COVID. So is that, do you think, because of comorbidities primarily?
Yes, and access to the care is also a big factor, like socioeconomic determinants. We call it social determinants of health, which has included the education, income, housing, transportation, and access to care. So those are the ones which are started talking about. And then I'm very vocal. We are talking with the governor and also legislators about the health equity. So the people have resources, because if we look at the healthcare, it all depends where we born, where we live, where we work, what is the environment. And these are the factors which are 80% out of the hospital system. So 20% is what we can provide to the patient, but 80% is the community health. And if we will understand as a nation that these are the factors, and because these things, after effects is basically managing your chronic disease spending, and the dollars we spend I showed about 1.65 trillion dollars, right? So how we can save that money, and why we cannot invest in the prevention and have those equity available for across the nation and with different ethnicities. So does that answer your question?
Yes, thank you. Thank you.
Okay, sure.
Okay, thank you, Professor Hibma, for sharing and for giving time for this webinar. Thank you, Professor Hibma.
Thank you.
Now I want to invite my next speaker, Dr. Yasir Bashir. Dr. Yasir Bashir is family medical consultant in Brisbane, Australia. He completed his MBBS from Rawalpindi Medical College in 2006. Since 2009, he was in Australia, completed his fellowship in family medicine with Royal Australian College. He is successfully running 2 primary health clinics in Queensland, Australia. He has keen interest in chronic disease management and skin cancer management and epidemic diseases. Please.
Hand over to Dr. Yasir Bashir.
Thank you for a detailed introduction, Dr. Shikufta. I'll just try to share my screen. I'm very new to Zoom, which is very unusual in this situation. Everybody's using it these days. Here we go. Can you see my screen there? Can you see my screen there?
Yes, yes.
Yeah, we can share.
COVID-19, which is most talked about thing at the moment in the whole world. So, first of all, what I would like to talk is, we had 2 great presentations, one from Professor Marilyn and Dr. Pasha. They spoke about New Zealand and United States, but I have prepared a more generalized talk about COVID-19, not focusing too much just on Australia and talking more in general terms. Since we deal more with day-to-day patients in the primary health, so I would probably more focus on the primary health side of things. So first of all, I would like to what the history tells us about epidemics and pandemics, what we have learned from them, what happened in the past. So Spanish flu was the biggest thing that happened in the past, and that was the one that has killed most human beings in the past. So this is something that started in 1918. It was initially an epidemic, then later on it was stated that it's a week they had 500. So they were surprised about the speed of the spread of this viral illness. As far as I know, this is Dr. Victor Vaughan. He was a professor at Michigan Medical School, and he had a lot to do with Spanish flu at that time. What his observations were at that time, what he stated was that he has seen hundreds of men in uniform coming into the wards of the hospital. Every bed was full. They were all the wards were, they had a bluish tinge in them. They had a cough, blood stains, sputum, and he stated that next morning dead bodies were stacked about the mob. So that's how it started, and the death rate was quite high, even early in the disease. From the military guys, it went out millions very quickly. It went all over the world: America, Europe, North Africa, India, China, Japan, New Zealand, you name it. So, and the physicians were saying that people are having typical symptoms of flu. So it has killed. That's how a ward looked like at that time. So it was crowded and packed. I think it's an image of a makeshift hospital that was somewhere probably in States. Similar pattern was followed with lot of makeshift hospital made all over the world in States, United States. In Australia, thankfully, we didn't need it. Probably, I'm not sure. New Zealand, we didn't have many cases here to have makeshift hospitals here. So, with Spanish flu, continuing with Spanish flu, everybody was at risk. In Philadelphia, they stated that 158 out of every 1,000 people died. So, illness can start from very mild symptoms to get severe very quickly. Different patients had different response to it. So the time we know that the onset is within 14 days, but the response after that is very varied in different patients. Some people developed symptoms very quickly, ended up in hospital in ICU. The others had a very mild illness. So it emerged from Hubei province, China, December 29, 19, belongs to coronavirus family, and the symptoms are typically of a cold in the beginning. So, and what we know more about this is a respiratory illness. So the spread is going to be droplet infection, like any other droplet infection, like influenza or any other lung infection. So it's spread. I would just touch base on the basics to provide the spread, to stop the spread of COVID-19, having a good hand hygiene, cough etiquette, all these guidelines that we generally see on TV and social media these days. So what's the current situation? So I got this from the WHO website. So they're comparing COVID-19 cases on a weekly basis all over the world. So in the last 7 days, this is dated on 20th of this month, within the last 1 week, if I'm not wrong, America had the highest share of total number of cases so far. 38% of total number of cases in last 1 week were in America, and Southeast Asia was 35%, Europe was 18%, Mediterranean was 6%. What good part was in last 1 week, death rate had a drop of 22% in America, and a massive rise in Europe, which is 27%. So that is what WHO has put out in the last 1 week. So the situation overall is not looking very good. We're still getting new cases all over the world. So talking about the economy and the impact on the GDP due to coronavirus. So if you have a look here at the bottom, so GDP fall, we compared to 2019. China was minus 3.3 so far. US is minus 8, which is the biggest hit. US had the biggest hit so far. Overall, all over the world is minus 4.9. With Spanish flu, the overall GDP loss was 5%. And we are in the middle of this COVID crisis. We don't know when it's going to end, and we are already at minus 4.9. So I don't know how the things will go from now on. So I will talk about the sectors, some of the sectors that were vulnerable. So travel and tourism, as Marilyn mentioned, a lot of countries that are dependent on travel and tourism as the main source of income or backbone of the economy. They are badly hit. And the aviation sector, they're expecting a $63 to $113 billion loss in the revenue in the year of 2020, which is massive. A lot of airlines are, and entertainment industry had a big hit. It's nearly 5 billion. Restaurants, hotels had a big hit. Agriculture to some extent, they didn't social distancing. They were isolated to some extent, performed fine, but still their produce was supposed to come to the market, travel and everything. They got hit for this. And sports, a lot of events were cancelled. Sports had a big hit in terms of revenue. Just coming back to COVID-19 itself, I've divided this into two categories. One is the physical implications, and the other one mainly the mental health and psychosocial aspects of COVID-19. So, if you talk about physically, organ-wise, COVID-19 it's a lung illness. It does cause lung disease, pneumonias. People have died because of restrictive lung failure, damage to lung tissues, and there were reported cases that patients who were COVID-19 patients. It does affect the brain and nervous system. There's loss of sense of smell, cause of paralyzation, immobility, sickness, heart attack, and stroke, cognitive impairment to some extent. It's too early to say that, but there's some cases the patient had afterwards some memory and concentration. Like any other viral illness, it does cause musculoskeletal problems, chronic pain, fatigue was seen as well. Coming to the mental health aspect, so this is where we deal with on daily basis in primary health. I have seen all over Australia, probably all over the world, the cases of mental health have gone because of people losing jobs, fear of unknown, not being able to go out, not being able to socialize, the depression, sleep issues, that has gone up. If there was a rise in suicide rate all over the world, I couldn't find anything too relevant. So if there was any study done, I'm not aware of that. Probably too early to say. Probably one of the other speakers would have an idea about this. If they can shed this light at some stage, that would be good. So about this study, there was more into mental health. So talking about the psychosocial impact, that was a lot of impacts had happened psychologically on people all over. They have, whenever there is a pandemic and unrest and people are fearful and they're not sure of what's going on, there's certain behavior patterns. And so I've tried to highlight some of these, like people started avoiding health facilities. They had a fear that if you go to a hospital or a medical center, any healthcare facility, they're going to end up seeing somebody who's infected there, or the healthcare workers might be carriers and they might get infected. So this means that people started putting their health in terms of preventative care or minor issues or ongoing medical problems on the back burner. So they were not seeking medical help until they had to when there was no other choice. So the patient numbers in primary hospitals, non-COVID patients we're talking about, the hospital had to close down their facilities for non-emergency surgeries for months, so that impacted the health as well. So the patient people felt a fear of losing their livelihood, they will not be being able to work, there was stressed about the isolation, they were worried, a lot of people were worried the job, which led to more anxiety and depression in them. And people had a fear of social exclusion, might get put in quarantine. If they go in quarantine, so they might catch something from there. And there was this initial part when people were, there was a talk that racism might flare up due to COVID-19, because earlier it started from China and people started calling it as China virus, and actually people started avoiding people that would get that it would be of an Asian origin. So that started in the beginning, but I think it has cleared up from there on, since it's not an epidemic, it's an endemic. So people started feeling powerless. They had a fear that they might be separated from their loved ones, and they might not be able to provide for the disabled people. I think the people with disabilities had a big hit as well because the carers were not available, not willing to go in, because they had a fear that they might get infected or they pass on the infection to somebody who has a disability. So that was a real challenge, especially in Australian health system, where we have very, very good system for disabled patients. And the so that was where a lot of problems happened. And there was a fear of people getting sick in nursing homes. And some of this has happened in New South Wales and Sydney. That one of the patients, one of the residents in the nursing home got infected. It got spread in the whole nursing home, had to lock down the facility. So that was one part of it. People were feeling helpless. There was a part of it, loneliness, depression due to being isolated. And there was this component that people who have experienced epidemics before, there was an unrest in them. They're reliving the experience of a previous epidemic. That was seen as well. So healthcare workers had problems as well, that they were worried that if they're going to work, they're going to get infected, they're going to bring the infection home, and they can get infected. But overall, all over the world, healthcare workers have done a great job. And on the line, they had this fear and unrest to some extent. A lot of people got infected. Like doctors mentioned, one of the doctors got infected and lost life. So that was part of it. That was one of the major impacts of COVID-19 on healthcare workers. So school closure was another problem. Kids couldn't get back to school. That increased the burden of the mothers and the people looking after kids at home. Homeschooling was a challenge. We had homeschooling here going on in Australia for months and months, which was not very welcomed and by children, by the parents, because whenever there was a homeschooling, one of the adults had to be there supervising. So it's not what people were used to. So that was a lot of stress in teachers, students, and the parents. I've mentioned this healthcare workers before. Let's see. In healthcare workers, there was more and more demand of them being at work, long work hours, patient numbers were more. I will just touch base on what would be the management strategy in short and long run. Of course, the vaccine is what could be an answer to and getting rid of this pandemic. But I wouldn't. That has been discussed before. What I want to discuss is more the general aspect of the things. What we need to have is a whole of society approach. That whole society globally needs to have their input in this in order to manage this pandemic and eventually get rid of this or control this at some stage. So a whole society approach, that's what is needed. So people need to be educated, clear information need to be given to people how to stop the spread, what are the measures we need to take. A lot of input should be put into mental health, treat and diagnose and treat anxiety and depression in time. That would be important. And apart from that, like I mentioned, information and a pandemic is a test for the resources. It does test the resources all over the world. So I think there's a lot to learn from there and prepare for an epidemic pandemic in phase one in future. Hopefully not, but I think there's a lot to learn from there. So last, I would like to mention that there was some good aspects of the pandemic as well. The environment probably would last for a while. So there were less carbon emissions, less waste, wildlife had a good impact, less energy usage, and overall the environment had a good impact. And with loss we had in terms of economy, the lives we have lost, healthcare workers we have lost, So I think overall, this is something we wouldn't want to have in our life. I'll conclude this here. Anybody has any questions?
Thank you, Dr. Yasser, for giving very good talk on the post-pandemics. Is there any question from audience?
Next proceed.
Thank you, Dr. Yasser.
Thanks for having me.
Our next speaker is Dr. Yasser Chima. He is research scientist, Quadram Institute Bioscience, Norwich, UK. His research interests are in molecular mechanisms of microorganisms. He had been awarded Darwin Trust PhD stewardship at the University of Birmingham, UK. It's my pleasure to join Dr. Yasser Chima.
May I share my screen, please?
Yes, show me. Please suggest.
I think
Dr. Yasser.
see Dr. Yasser Bashir's screen.
Dr. Yasser, will you please close your?
All right, just give me a second, please.
Thank you, Dr. Yasser.
I think you can see my screen.
Yes, we can see your screen.
Good morning, good afternoon, everybody. I'm Yasser, and I'll be talking about today sequencing techniques we have used to sequence COVID-19 and how this tool has guided us through the pandemic. So I'll be talking about Quadram Institute, where I work, and then I'll be talking about a little bit about coronavirus and consortium of genomics in UK and sequencing techniques we have used and post-pandemic changes that this COVID-19 has brought at work and in our community. So on left-hand side, you can see the overview of Norwich Research Park. Norwich Research Park is the place where 4 research institutes and a university and a hospital, they are working together to improve on many aspects of science and health. So on right-hand side, you can see the picture of Quadram Institute. So Quadram Institute is a good example where clinicians and scientists come together to solve big challenges. So at the basement of this building, we have that does about 40,000 colonoscopic procedures every year. And on the top 2 floors, we have scientific facilities that we use to help clinicians to find the solutions to all the challenges. So this institute focuses on gut health, microbiome, and lung health. So as COVID-19 is a disease for, as you know, that respiratory tract, so we were called upon during the pandemic in this regard. So I think there's no need to share this slide, but I have just brought it. COVID-19, everybody knows about it. It's an RNA virus, and its genome size is about 30 kb, and it causes respiratory tract infection. So the diagnostic tests used for COVID-19 are either we detect the nucleic acid or we use the antigen detection tests or antibody detection tests. Those are colorimetric tests usually. So PCR is a standard test used all over the world to detect COVID-19. And in the process, we have to extract the RNA of the virus. And as we have the RNA of the virus, so it was thought that what we can make best use of that material when we got that. So all the funding agencies of UK and the research institutes, they come together and they thought about, if we could sequence all the samples that are positive, then we will be able to track and trace all the evolutionary mechanisms and the spread of the virus. So it was a brilliant idea. So for that, all the funding agencies, they came together, and like Cambridge University, University of Birmingham, and Quantum Institute, Sanger Institute, and all the major genomic institutes of the UK, they come together for that. So for the sequencing, it's pretty simple. The RNA we get from the positive patients, the leftover RNA after a test, we convert that into DNA. So this is usually single-stranded DNA, then we convert it into double-strand, and then the challenge comes that DNA is in very small amount that we get from the leftover samples. So we need to amplify the DNA for the downstream sequencing. So usually, my screen is frozen. Okay. So Multiplex PCR was designed to come around this challenge. So this is a 30 kb, 30,000 base pair genome only. So 98 primer pairs were designed to amplify 400 to 500 base pair fragments of DNA. So basically, the whole 30 kb row, and then we put the DNA on a flow cell of Illumina, and all the fragments that have those black or gray adapters, they will attach themselves to the flow cell, and then we multiplex them. It's a PCR based method, and then the instrument detects fluorescently which base is being added at what step, and then by this way at the end we are able to see the sequence of the genome, whatever we have put in the library. On the other hand, in Nanopore sequencing, we add slightly different adapters to the end of the DNA. And the principle here is there's a tubular protein, and only one strand of DNA can pass through it. And as the DNA is passing through it, it causes disruption in the electric current that is flowing through that tube. And the instrument detects the disruption in the flow of electric current and records as a signal. And each base produces a different disruption. So that way we identify what is A, T, C, and G. So you are seeing an interesting device on the screen. So it is a small device. It's like slightly bigger than a USB, and it's much smaller than a smartphone. So you can carry it anywhere if you want to around the world for sequencing. So that's one of the advantages of nanopore sequencing. If we want to sequence it in one place or another, we can just simply hook it to the laptop and start sequencing anywhere in the world, outside, like in the field or in the labs, or where the sequencing facility is not available. So if we compare both platforms, there is like some advantages and disadvantages of each platform. So the question would be, should we be using Nanopore or Illumina? So the answer is, if you have many samples, like hundreds of samples to sequence, I think Illumina is a better choice. And if you have few samples, then Nanopore could be a good choice, because you do not need to buy expensive instrument. You do not need to have expensive kits. And because in Illumina, if you run like few samples, then the whole kit is wastage. And in Nanopore, on the other hand, only it can handle up to 94 samples. So if you are doing 10 or 24 samples, that's pretty good in that sense. Just disclaimer, I'm not sponsored by Illumina or Nanopore. So we did a comparison of both methods in Quantum Institute, and we find out that with the high CT values. So these CT values are the cutoff values that are coming from the PCR, from the diagnostic test. The tests are same, either they're coming from the corona hit or Illumina. And at low CT values, they are producing the same results. But at high CT values, the specificity of the test become quite can you hear me? I can hear just noise in the system. Can you hear me?
Yeah, we can hear you.
Okay. So the next challenge after doing the sequencing is data analysis. How to analyze the data and what that means basically. So we can see here that each line, there are many lines here. Each line is representing a strain that appeared in the community, and at the x-axis you can see the weeks of the pandemic in UK, and the right, the number on the y-axis we can see the name of the strains that I believe you won't be able to read. So, but you can see the lines, and they are the green line in the middle, the top one. This is showing the first strain that was introduced in the community, and the other strains, they appeared later on in the process of evolution, or they were introduced at different occasions into the country by travelers. So some of the strains, they came and they persisted throughout, almost throughout the pandemic. But rest of them, you can see that they appeared and then they died off. So you can see the full detail of data on the website of COG UK website. So here I want to play a short video, if I could. So on the right hand side, you can see the strains, and there's the map of UK here. So you can see that when we click on each strain, it tells a spread of that strain and where that strain was identified or moved around in UK. So this is a very valuable resource, and by using this resource, we have been able to identify many outbreaks in the healthcare settings and old homes and like in the community. So either the sequencing coming from Illumina or Nanopore doesn't matter if we analyze it well, and we can relate it back to the community and its epidemiological data. Then we can infer valuable information from that. So now what post-pandemic work effects are. So on the left-hand side, you can see the office, that was Quadrum office, and it's empty. So we are not working from office nowadays. We are working from home if it's possible. And one-way walkways are marked all over the place, so you can only go through only one way and can come out through the other. So it is just to make sure that nobody crosses each other's way. And at the work in the lab, so it is quite tight in the sense like you can only go there by booking slots, and then you can go there, work there in the respective place, and then that you have booked in the marked boxes, and a restriction as compared to past. So where you could go in the office and then plan your day and then work whenever you want to, wherever you want to, and then come back at your own convenience. And all the meetings and seminars that used to happen, they have gone either on Zoom or Teams or Discord. So it's quite a big change that has brought in the work life. And as the earlier speakers, they have mentioned in detail effects of all kind of the COVID has brought in the community. So it has brought the friendships are not same, like you don't meet your friends for coffee or dinner anymore. So you ask them, do you want to go for walk, or if the weather is generous, you can meet them outside in the garden or somewhere. And the shoppings have changed altogether. You need to wear mask if you go to the shopping center. Otherwise, online shopping is an option. And travel in the public transport has become altogether different. Now you need to wear masks and you need to keep the social distancing. And learning experience, as you, I think, I'm pretty sure the university is facing as well. So in Pakistan as well, like all the classes are online, and all the learning teachers have to make the presentations and then deliver online, and the students, they have to ask like all kind of queries online. That's quite a different and challenging environment. And for the practical classes, it's almost impossible. And all this has brought huge impact on the mental health, either like in academics, in clinicians, and either the person is like working in any other field of life. Because of the COVID, it has brought a huge impact on mental health of all people. And as Dr. Pasha has mentioned, that there are like people who have lost jobs and the economic situation. So mental health is the biggest issue we are facing all around the world. So the new normal is like is a general advice in UK at least, that stay home if you have any symptoms of flu or cough. Do not come out of your home, or do not come to work at all. Keep 2 meter distance whenever and wherever possible. Keep wearing masks on public transport and shopping centers, and try to travel less and meet minimum number of contacts. Wait for vaccine and pre-pandemic normal. And I believe that won't be pre-pandemic normal. That will be post-pandemic normal, and it will be new normal. Thank you very much. Stay safe and stay healthy. And thank you to the COG UK team and Quantum Institute sequencing team. Thank you very much.
Thank you, Dr. Yasser. Any questions from audience? Yes, sure, Dr. Zishan.
Yeah, so Yasser, great presentation. The only thing, because my concern is how.
Thank you. It's a very good question. The relation, as you know, that the data is kept quite confidential here, especially with the NHS as it involves. So the studies that are being conducted, they are still not being made public, or they are not being kind of brought into the publication domain yet. So, but I think as the general perspective, or the general thing that data shows overall is antibodies in the response is almost, we cannot relate with particular strain at the moment. That is the general kind of consensus. But the virus load is the cause of the disease. That is kind of established now. Like, it's not the type of the virus, it's the virus load. The number of the virus is maybe the more dangerous. That is one of the studies that came out 2 weeks back. So as the vaccine development prospect, as you mentioned, which strain is producing more antibody response as compared to the other one, we do not have any clinical data, because we are just sequencing that, and we are not measuring the antibodies and not comparing, mapping back to that at the moment. Or we are doing some longitudinal studies in which we are measuring the same person on the longitudinal sampling for a few weeks, the positive samples and some other community that are negative samples, and we have the data for those persons. But I think that study is still in the process, and it will be hard to say anything about that. I hope I have answered the question.
Thank you, Dr. Yasser. Thank you for giving a very good talk.
May I ask?
We want to invite Professor Javed Akram. He is an eminent professor of medicine in Pakistan. Professor Javed Akram was the founder, Vice Chancellor of Shaheed Ali Medical University, Islamabad, and CEO of Science Institute of Medical Sciences. At present, he is serving as Vice Chancellor, University of Health Sciences, Lahore. founding president of the Inter-University Board of all medical universities of Punjab, founding president of Pakistan Society of Internal Medicine, and chairman World Ramadan Study Group. He is an author of 6 groups and around 100 research papers. He is a clinician, a laboratory researcher, a medical educationist, a health delivery administrator. He is presently leading a group working on the cloning of human pharmaceutical protein genes. Professor Jalal has been decorated with Prime Minister's Gold Medal for research in the field of the Parkinson disease, Best Research Award by the National Academy of Medical Sciences, and Tamga Imtiaz by the President of Pakistan. Thank you, sir, for joining. And you are very busy, and you are going somewhere to attend some meeting, and we are feeling very happy. Our player to join us.
Thank you so much, Dr. Shagufta. It's an honor and pleasure. And I'm sorry I'm traveling back from Islamabad to Lahore right now. And I'm very grateful to Dr. Shah Jahan of my university for arranging this webinar for me. Very informative. I'll say that we are not into post-COVID as yet. We are still into COVID. So the important thing is that I think what we see in Pakistan is that people are really relaxed and they think it's all over. While my own thinking is that it is still very much there. And still we are losing 5 to 6 people and sometimes 10 lives a day. And still people are getting infected. The more we ignore the protective SOPs, the more we are going to be getting the cases, and nobody is as yet safe. We are all equally vulnerable. So parts of the world, and we know in UK that they are still again struggling with this virus, and especially in the populated cities. So I think it's very important that we keep emphasizing on each other and our near and dear ones and in our institutes that we must continue to be extra vigilant and careful. As far as the vaccine is concerned, it's too early. We are doing 2 trials right now on vaccines. One is insect-based vaccine, which we developed along with Flinders University in Adelaide, Australia. And this is the technology by which vaccine was developed for SARS-1 and also for many other viral infections, where we feed the insect, we use it rather than using E. coli or yeast cell, we feed them with amino acid sequencing, and vaccine is. The advantage is that there is no chances of infectivity from the virus because it doesn't contain the virus. It just contains the proteins manufactured by the insect. So this is one study that we are undertaking in collaboration with the Flinders University. Another study that we are just starting actually in next 2 days, and that's the Chinese vaccine, and that's an active vaccine where the virus itself is being used after modification to generate the antibodies. We do not know as yet. It's too early to say because we are only into phase 3 trials right now. Safety is reasonably established in both the vaccines, but the issue is that antibody generation is there, but the big question is for how long the protective antibody will be there. In about 3 months' time, depending upon their antibody response, the quality and quantity of antibodies. But we don't know as yet the protective mechanism. We have been doing more than 19 studies, and many of us, we have published about 9 papers already. One trial that we did at our university with 13 centers around Pakistan is called Protect Trial. Pakistan randomized outcome clinical trial in coronavirus patient. And this trial, we used 8 different parallel arms. One was oseltamivir, which is an antiviral oral drug, and one was azithromycin, and the third one was hydroxychloroquine, and then various combinations of these drugs. And one of the arm had all 3 combination, and we released interim results of 1,500 patients. And very encouragingly and interestingly, the patients who were assigned to the all 3 drugs arm responded very well, and the recovery was seen in almost 1 week. And the recovery means negativity of the RT-PCR. It was seen after 1 week of treatment in 87% of the subjects. So very encouraging, and we had mortality, but less mortality in the group that we used all 3. And then there was a placebo group, so we compared it. Obviously, it's an ongoing study, but we made already interim release, which have been published in trial.com from US, and it can be look at anybody. We have already done a study with in critically ill patient on many drugs, including colchicine, which is a drug used for gout, and also we have done trials on interleukin-6 inhibitors and TNF inhibitor. We have compared infliximab with tocilizumab, and we have found them to be very comparable, no superiority or inferiority between interleukin-6 inhibition and inhibition of TNF-alpha. So there are many trials that we are still ongoing, and we are following up these patients. The important thing, I think, the post-COVID should be that since we know that the COVID is still there and it can always come back, we as individuals and as community must be prepared to counter the second wave and the third wave. And I think we should continue to practice precautionary measures. But at the same time, we know that the mortality is about much higher, about 2 to 3 times higher in smokers. So just to be prepared that if you unfortunately get infected by this RNA virus, COVID-19 virus, then you stand a better chance of recovery. If you are a non-smoker, if you are obese, your mortality rate doubles. If you are a hypertensive and if you are uncontrolled, then the mortality is very, very high, around 11%. And if you have underlying cardiac disease, it is 19%. So I think all the people living with comorbidities, whether diabetes, hypertension, they must control their underlying condition. They must be in good physical and mental health to face this second peak or whatever if it occurs. And in any case, it will improve. I'll say that being a practicing Muslim, if cleanliness is 50% of our religion, and if we bring that 50% into our practical lives, it's going to save us from a lot of hassle. All the species switch occurred in Wuhan from, we know that this was from bats, horseshoe bat, Chinese bats to humans. And this vulnerability will remain with exotic animals, especially bats, snakes. But fortunately, we don't eat them. It's forbidden in our religion. And that's the, blessing of Almighty Allah. And we don't eat these things raw. So I think this already, the word lifestyle of a Muslim is proud to say most healthy lifestyle because
quick internet problems.
In farming of these animals, we don't in these farms to all these which initiatives, and also that we wash our exposed areas at least 5 to 6 times a day is again another blessing. So I think as a Muslim, I'll say that many things are prevented if you practice our beautiful religion, and once again I'm very grateful. Yeah. Thank you.
Thank you, sir. Any question from audience?
Yeah, Dr. Javed, this is Dr. Zishan. So thank you for being with us. You are leading a greatest institution in the country. So I just want to get your perspective about how readiness about the healthcare systems to combat COVID-19. And especially if you look at, I'm a graduate for Nishtar Medical College, you look at NMU, the vice chancellor, Dr. Pasha, has died due to the COVID. So it really concerns me, like the doctors who are treating the patients, how safe they feel themselves while treating COVID in the healthcare system in Pakistan.
Thank you so much, Zishan, and it's a pleasure talking to you. Yes, Mustafa Kamal Pasha, just like a brother to me. We miss him very much, and I'm sure he's in a much better world than us, and I'm sure he is enjoying in the paradise, because Shohda deserves this. He, being a surgeon, he was taking rounds of all these wards. Despite me telling him not to do so, he was continuing to do so. So I'm sure Allah will give him highest place in Jannah. As far as your question is concerned, I think I worked for NHS for about 9 years, and I know, and I worked in US and other countries. And unfortunately, in Pakistan, our health policies are aggressive and not progressive. And also the aggression is mainly driven by the media. It's not by the facts. It's driven by how much attention media gives to certain issues. And it's not a true, a proper way of delivering the healthcare to masses, especially in a country which is potentially going to be the third largest country in the world. Our health system is very weak. We only rely on the tertiary care hospitals, and we spend on the tertiary care. We are not spending on primary care and secondary care. Thus, we only get complicated diseases and not disease early on to intervene. My point is that when we see dengue, we all run after dengue and we get the funding. When there's a COVID or corona, we do that. It's issue-based spending, issue-based resource allocation, but that's not the proper way. You have to have a functional healthcare system, whether it is villages, whether it's primary, secondary, or tertiary, and then you can combat all the diseases very well. As far as PPE, protective personal equipment, I'm seeing doctors who are well aware, well educated, they unnecessarily are exposing themselves right now, because they are also going into thinking that they are into that honeymoon thing, that probably they are thinking that it's all over. So that is why they are exposing. Although PPEs are available, rather they have become inexpensive because the need is not there now, and you can find at quarter of the price PPE, masks, or hand sanitizer. We are using PPAR, which are respirators with the helmet-based respirators. And I still am seeing the patients in ICU and all that, but I see them after PPAR, purified respirators. And I think that is important, that we need these health cares. It's very good to die a death of a martyr, but if we all die and we all become ill, who's going to look after the patients? That's why we need to continue to stress on the protection of our healthcare providers, the frontliners.
Sure. Thank you, sir.
Thank you, sir.
And
Because you have given very good
back to
suggestions
Lahore.
regarding Corona situation in Pakistan.
Sorry, can you say that again?
Thank you, sir. Thank you, sir.
Okay. Thank you so much.
Thank you, sir. Now our next speaker is Dr. Shah Jahan. He has done his PhD in molecular biology, virology from CEMB, University of the Punjab, and now working as associate professor at University of Health Sciences, Lahore. His research interests are molecular biology, immunology, microbiology, genetics, virology, and cancer biology. He has 66 research publications in international journals, and he has completed 7 national and international projects. Recently, he has been awarded the project from HEC on the immunological basis of the COVID-19. Dr. Shah Jahan, please join.
Hand over to Dr. Shah Jahan. We are seeing Dr. Shah Jahan's screen, but Dr. Shah Jahan, will you please start your presentation?
Dr. Shah Jahan, no voice. No voice. We are not listening you. I think you are having some internet issue.
हमारा प्रॉब्लम है इनका है।
Hello.
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 Yes, Dr. Shah Jahan. Yes, Dr. Shah Jahan, we can hear you now.
Okay. You are hearing me now?
Now we can hear you.
Hello.
Yes, sure.
Dr. Shah Jahan, now we can hear you. Previously, we were not listening to you.
I'm not getting any sound now.
Dr. Shah Jahan, we can listen you now.
I think there is something wrong. Hello.
Yes, we are listening you. Please start your presentation.
Hello. Have you? Hello.
Yes, Dr. Shah Jahan, we are listening you. Please start your presentation.
Okay. I'm going to start that. Being the last speaker in this, I am going from my mobile now. So there will be some difficulty. The title of this was post-pandemic. Hello.
Dr. Shah Jahan, we can hear you. So please, you can start your presentation.
Hello. Are you listening me now?
Yes, we are listening
now. Okay.
Yes, we are listening.
Now I am coming with video.
Okay.
Hello. I have changed my sets. I think you are now listening.
Yes, we are listening you.
Okay. Okay. I think this is afternoon time, and being a last speaker, there are some IT problems.
Dr. Shah Jahan, maybe the problem is with you, not at our end.
COVID-19 health and community. But I suggest that, as Dr. Pasha and Professor Dr. Javed has discussed, that this is not post-pandemic era. It is is still prevailing. As you know, that emergence of two already coronaviruses, MERS and SARS, already has damage, but the time, duration, and area which was hit by previous coronaviruses was specific and time bound. But now the COVID-19 has prevailed all over the world, and being a global village, it has suffered a lot. The figure shows that this has not gone. Still, there are the figures that are showing that these are the recent figures of 21st September 2020, showing that there are still 22,000 which are prevailing and causing the death of 4,000 every day. So we should admit that now still game is on, COVID is here, and we have to combat it. So the question that the region where it has eradicated in New Zealand and in Pakistan, but when we compare the case fatality ratio, it is high in some area, in Brazilian population, in Spanish population, and the other like USA. But fortunately, that in Pakistan, the death rate was very low. And as compared to Pakistani neighboring countries as India or other, that we are still safe. And there are the maybe difference due to immunity and the other. Pakistan is showing definite slowdown. 6 deaths in last day, but it was increased. And some people are thinking that maybe it will be a second wave, or it will be because the one thing which Pakistan government is going is very good, that we are not going to decrease test. We are doing 31,000 tests per day. These showing that 633 positive. But in last week, it was 600 in whole week. But last 2 or 3 days showing figures 452, 550, and 633. It means that opening of schools, educational, and other after lockdown, now maybe there will be a second wave. So we should ready for this one. Screening at the airport and other public places are in process, so it will help us to combat it. Government has started now micro smart. I was thinking that there will be maybe in next phase there will be a nano smart. It means that people will not be stuck in their homes. Maybe they will be stuck in their washrooms to maintain or quarantine personally. As a health system in Pakistan, as Dr. Javed has told, that with limited sources, Pakistani warriors has combated very well. The warriors, frontline warriors, they have faced many things. Many were infected and many were expired. But the main thing was that they were in the field and they worked hard. And the one thing which was very important in this case was that they quarantine and isolate, and they permit the people to stay at their home to provide the services. Because this was very important. If we give anyone to stay at home with infection, if there is moderate or minor, then there is no need to go to hospitals. Because when they were going to hospitals, they were suffering, the travelers, the passengers who were traveled with them. And the condition of hospitals was not very well, oversaturated, and that was causing threat not only for the patients, but also for the doctors. And so the step of the government of smart lockdown was very good. It worked, and hopefully it will be in process. These are the pictures after lockdown. After it can be said that after post-pandemic in Pakistan, now schools are opening, and we are looking that we are witness that students are sitting at the distance, and they knows that distance prevail. How they are monitoring the temperature, they are going to spray everything, and this will help to get benefit for this. These are some funny one, because afternoon many one are going to sleep, and being a last speaker, I was showing that 2020 lectures are going online, and I think YouTubers are earning a lot, and many things are going on because people have the time and people have the connections, and the community has the different. And now education e-learning and the other things, and medical, as telemedicine has changed the world that people. These are the recent papers in just for view that those people who are thinking that maybe a person is infected, and if it is infected and have severe symptoms, it maybe has long duration antibodies. Antibodies mediated immune system shows that there will be decline in antibodies after a short time in those who were infected, moderate or normal, and who were severe, they were no. And the one focus on it that they have got a sample from sewage and they found the RNA because there was a lot of burden. That test was not happening at the spot. Then they decided in a population, in an area in town, that they go to sewage water and collect it, and it shows that really still there is a viral RNA and COVID is present. So these researches are very important. Now strategies to control has been changed. As in therapeutic drugs, that oral plasma therapy and the other has been now on hospitals, and the direction of research has been changed because the people who are working on these things now are focusing on the other things.
We are listening to you, Dr. Hello.
Okay.
Hello.
Now, the one scientist is from US has said that I am almost certain it will come back because the winter is coming, and these coronaviruses which are respiratory causing respiratory problem and comorbidities with respiratory problems may be more severe. Is the example of the in graph I am showing is of Hong Kong, that there is already second wave has come, that cases has been declined, and now after the 6 months there is again a second wave has been prevailed. Now the focus should be at, I admit, and other virologists admits this, that if there will be second wave, as Dr. Yasser from Australia has given example of flu, that it will be more severe, as there will be reinfection. It may be because there will be the change of strain, and in the case of other things, it can be more. So we should take measures of social distancing, testing, tracking, and other things. We should not relax because the stop additional wave on. You all know that the condition of hospitals was so vast, and once at the time we were saying that all things are choking, but it was the belief and the contribution of our medical professionals that were standing, and they helped a lot. The other thing which we should focus as in post-pandemic or pandemic era, that what should we cases that to combat with vaccination is. Now come to other part of this topic was post-pandemic effect of COVID on not only on health, on community, but if we say overall community, there are the many things that this pandemic caused. Infodemics. Infodemics mean that a lot of information without check, that people were saying that ethanol is the very good for the health, and the people were drinking ethanol, and it happened in Iran, and we are witness that there was a darknet, and others, a lot of social media, the garlic, the maki sanya, and other things which are very important, but we should focus that there is scientific proof for this. So this COVID pandemic given people a lot of time, a lot of theories, and this caused a lot of burden on the media. This social media should be a check, or should be we follow an authentic information. The other thing which Dr. Pasha has told, that there is a lot of unemployment due to COVID, because after COVID-19, many private and public organization was not working, and the employment caused a lot of torture as a mental health and other, which has been Dr. Yasser Bashir has told that psychological problems are there, because if people are not getting job, they are not getting money, and they are going backward, it will maybe a post-pandemic effect on community that will affect our behaviors, our working behaviors will have been changed. That when I was sitting here, many students were there, but now I have to check the students, that only one student at one time can come and can join for discussion for the research and other things. hospitalized, and the patient which was normal to moderate and they have not symptoms like cough and other things, but they were positive. In this, we will go for transcriptome analysis, as that host genetics is important, cytokines level, cytokines variation, genetic variation in the receptors which are important for the infection, and other tar-like receptors. We are going to for genome sequencing, and then for EMS and protein mapping, as we have collaboration with Professor Dr. Himma, and we will work on the antibodies, and we will go for further mapping and other things that will help us to study the patient, and maybe there will be different things, and research will be on this. Okay, thank you. I think now there will be no sound or voice problem.
Okay. Oh, yeah, there is no sound problem now. Thank you, Dr. Shahjahan. Any question from the audience for Dr. Shahjahan?
Yeah, this is Zishan, and Dr. Shahjahan, great presentation, and I would like to congratulate you on your grant. I think it's a really good milestone.
Thank you very much.
For Pakistan, and I think you guys are doing really great and excellent work to do all those which is happening. And can you give your vision, like how or what your plan is for Pakistan based on those research that can benefit the community across the Pakistan, and as well as nationally, internationally?
Thank you, Basha. As our Worthy Vice Chancellor has mentioned, that our university has played a vital role in COVID-19 infection, because we were not only providing services with telemedicine, we were providing facility of PPEs, masks, and other by donating to the public, to community, and to our health professionals, because our university is focusing on the not only the education, a standard education for all medical colleges, but we are on the back of our clinicians and our other partners. And we have made a research group which were doing clinically research on different topics, like our one trial was on this was a very good project. We got Pakistan randomized and observational trial to evaluate coronavirus treatment, and we found many better things, and we are hoping that Karachi, it will be fruitful for community, and the research which is in our domain, this in which we are going for plasma therapy, or the other with Professor Dr. Fredun and Dr. Javed Akram, I think it will be useful for community. Thank you.
Great, thanks.
Okay.
Thank you, Dr. Shufta. Is there any question?
Okay. Thank you, Dr. Shahjahan.
Thank you, Dr. Shahjahan. Now I want to invite our chairperson, Professor Dr. Khanvinar.
So we conclude this seminar by saying that COVID-19 is more than a health crisis. By stressing everyone, one of the countries it touches, it has the potential to create devastating economic and crisis even in the health sector also. So I am thankful to all the honorable speakers. Vice Chancellor Professor Dr. Javed Akram, Vice Chancellor University of Health Sciences, Dr. Yasser Bashir, Queensland Health, Brisbane, Australia, Dr. Zishan Pasha, Associate Professor, University of Illinois, Chicago, USA, Professor Dr. Merlin Hibma, University Otago, New Zealand, Dr. Asirja, Research Scientist, of seminars and creating awareness on the students, faculty members, as well as among the faculty members, as it is the need of the hour to continue such kinds of seminars regarding this post-pandemic effects on the health and community. So I hope that everyone, the speakers as well as the listeners, this webinar will play an important role imparting the knowledge to the community on this important health sector as well as on this education sector. Thank you very much.
Okay, on the behalf of Policy Department, I will explain trajectories. Thank you for all the participants as well as especially speakers.
Great.
On
Thank you, everyone.